All right. Well, actually, we're right on time, which I'm pretty excited about. And so we have a pretty big panel in front of us today, and I'm going to go ahead and transition to our active shooter panel, if that's okay with the audience. I didn't see any hands go as far as strategic planning. Anything else, Ed? It will do. So I'm going to start off. Yeah. I'm going to start off by our order of operations today as far as the active shooter event that happened at Deaconess Hospital. We're going to play a quick clip from KXLY that will introduce kind of what happened. And then we have representatives from Spokane Fire, Deaconess, Rockwood, Spokane Police Department, Shriners Hospital for Children, and the Center for Personal Protection and Safety here today. And so we're going to start with the KXLY clip, and then we're going to run through 10-minute presentations from each of the panel members. And we'll ask you to reserve your questions until the end. And so we'll get a perspective from each one of the organizations on how they dealt with this event, and then have about 20 minutes to ask questions and go from there. Sound like a plan?
A troubled marriage has come to a violent end inside Deaconess Medical Center. That's where Spokane police say a husband shot his wife, then turned the gun on himself. We have KXLY4 in-depth coverage of the Deaconess shooting. Kylie Cruz spoke to a woman who was there when the shooting started. But first, Jeff Humphrey, who was the first reporter on the scene this morning at Rockwood Cancer Treatment Center. Jeff?
And Nadine, it was about 9:38 this morning that the first calls began coming into 911. People up on the 7th floor of the Deaconess Health and Education building told dispatchers that a man armed with a pistol had gunned down his wife in front of her co-workers. Police and firefighters came from as far away as Spokane Valley, concerned that a gunman inside a hospital would find plenty of easy targets.
I was kind of wondering what was going on, why they would need paramedics and fire trucks for a hospital. Officers
raced to the 7th floor Cancer Care Center, where Sarah Levine had barricaded the door of her mother's room after hearing multiple gunshots.
I sat on the bed against the door and laid stretched out so he couldn't get in.
Meanwhile, the Spokane Fire Department's new rescue task force, paramedics wearing ballistic vests and helmets, worked their way toward the shooting victims.
3 teams in total up to the 6th floor, staged them in a stairwell. As soon as the area was rendered safe by the police department, we moved those assets up to the patients and they immediately started care.
Unfortunately, the unhappy husband had shot his wife multiple times, and even though the rescue task force packs in advanced medical care, they were not able to help her.
The preliminary information indicates this was a husband and wife. The husband came to his wife's place of employment, which is in this building here, and shot her before turning the gun on himself.
The murder-suicide happened so quickly the building was really never evacuated, so most patients with their own medical needs were still able to keep their appointments.
The only thing we have shut down, the police have shut down at this point in time, is that particular suite in which the shooting occurred. Access to the building is not restricted in any sense by the police.
And Nadine, as soon as investigators realized this couple had children, they used their police chaplain to notify their guardians. This morning, these kids had 2 parents, but tonight, because of the selfish actions of their father, they don't have any parents. Report, Nadine.
Jeff, do we know anything else about this couple's marriage?
Well, until either the medical examiner or Deaconess releases the name of their deceased employee, it's kind of hard to go through court records and find either protection orders or things like divorce proceedings. We have heard that either the Spokane Police Department or the Sheriff's Office may have responded to a domestic violence call at this couple's home. We are hoping to have more for you tomorrow so we can learn from this tragedy and do a better job of anticipating and preventing domestic violence.
All right, thank you, Jeff. And it was a terrifying morning for those on that hospital floor where the shooting took place. One woman even barricaded herself in an exam room when she heard the shooter was inside. KXLY4's Kylie Cruz live now outside Deaconess tonight with her account of what happened. Kylie?
And Nadine, Sarah Levine is already going through enough. She just found out her mom has cancer, and today was actually her mom's first appointment here at the 7th floor of Deaconess. That appointment, though, cut short when a gunman entered their floor and opened fire.
We're going to go ahead and cut it there. It goes to a personal interview story, which is fantastic to watch, but probably not entirely appropriate for what we're doing now. So with that, speakers, you have some microphones in front of you. There's a small button in front of them, and if you do want to activate it, it's got a red light blinking indicating it's off, and then if you hit that little button, it'll start blinking green, and the mic will be active. Sound good? Okay. So we're going to go ahead and start our panel discussion with John Solano and Barbara Strump from Rockwood Clinic. And so if you go ahead and make sure your mic is on, and you're welcome to stand up and use the podium or stay at the desk, but either way, please take some time and fill us in.
Go ahead, Barbara.
Hello, I'm Barbara Stump. I'm the Director of Risk Management at Rockwood Clinic. My partner here, John Solano, he is the Safety Officer at Rockwood Clinic. And I have to tell you, looking at that video again brought back a lot of painful memories. I thought the emotions were gone, but when you see that, they're not. That was quite a day. On that day, domestic violence brought violence into our workplace, Rockwood Clinic. We are a diverse, large organization. We have 50 physical locations and 1,300 employees, and that's just our clinics, outpatient services. This event occurred in our oncology lab, which is located, as the reporter said, on the 7th floor of the Deaconess Health Education Center. And within that clinic, there are physician offices, there is a research center, there's an IV infusion suite where patients who have cancer are getting chemotherapy, so they're hooked to IVs and there for several hours while they receive their treatment. And we have a satellite lab, which is within the suite itself and next door to the infusion center. On the morning of July 8th, there were a total of 43 people in our clinic. There were patients in the waiting room. There were 2 receptionists and a scheduler. We had 8 patients sitting back in the IV infusion suite, so they were sitting in chairs which reclined, getting IV medications. There were 4 RNs taking care of them and 2 medical assistants that were taking care of their needs. We had multiple physician offices in the back and patients and medical assistants coming and going and being treated for cancer back there. We had a research center that had a couple of patients in it. And we had that satellite lab, which is located right within the clinic.
About 9:30 a.m. on 7/8/14, the shooter entered Suite 700 at the Deaconess Health and Education Center through an unlocked employee entrance. And the door was conveniently unlocked. It's the only lab that Rockwood has in that building, so it was used by our other facilities there. What happened is he entered and he had been in that area before, so he enters the door and goes up towards the lab. The lab, again, like Barbara said, is in the infusion center. And he notices at that time a patient seated in a draw chair, and the victim was taking a sample. He waits outside of the lab until the patient is done and walks out of the lab and into our lobby. At that point, he walked into the lab. He fires one time and hits the victim in the head. She falls. We fired multiple shots thereafter, and then put the gun to his own head and fired the last shot. In the lab at that time, there was another employee, and when she saw the shooter come in, she hid behind a refrigerator for her own protection. At about 9:37, I get a call at my office from the receptionist, who was at the time hiding under the desk under her reception area, that 2 people are dead in the suite, and she's calling 911, which she did about 30 seconds after she hung up with me. The response from the police department and the fire department was outstanding. We're eternally grateful to those gentlemen. At around 9:38, the call was made to the 911 operator, and with about 9:43, the police started arriving, and shortly about the same time, so did the fire department, and I arrived about 9:45.
I was on vacation that day, and my first notification was from my daughter, who sent me a text, 911. She works at Deaconess in the hospital pharmacy. She said, you have a shooting in one of your clinics. Quick, get here. So I jumped in the car and went to the clinic. While the employees were calling 911, the nurses in the infusion suite were caring for their patients. Now remember, that infusion suite was in an area about like this, and the lab would be right where these two gentlemen are sitting. So very, very close proximity to each other, with a half wall separating the suite from the lab. So our patients and the nursing staff heard everything. Many of them saw a lot. The nurses ran in front of their patients and protected them. One patient said, "You get behind me, I'm dying anyway." She said, "Not on my shift, you're not." So she grabs his IV pole and drags him down the hallway. We had locked doors. As you heard on the video, patients barricaded themselves in. All of our patient rooms have locks on the door, so people brought patients from the waiting room. We had a patient who was an off-duty physician who grabbed many of the patients and took them back behind the infusion suite to other offices with locked doors.
As best we could, after the police had control of the suite, Barbara and I went to the other clinics that we have in the building.
We're not quite there, though.
What's that?
We're not quite there.
Okay.
That was at the end. Just a minute. We've not rehearsed this. So I was going to talk about the medical care. Okay. All right.
Sorry.
So first, the staff took care of the patients who were there, put them behind locked doors. It was obvious that the shooting was over to our staff within the clinic because the shooter had shot himself. So many of the staff knew that it was safe to come out and care for the victims. So two RNs that had been in the infusion suite, the physician that had been in the waiting room and another physician came to care for the two victims. It was pretty obvious that our employee was dead. She had 6 gunshot wounds to her. Laying within inches of her was the shooter, and our staff began to work on him. You can imagine the thoughts that were going through them. He had just shot and killed their coworker. That was pretty tough, pretty tough. Our protocol in any Rockwood clinic, because it's an outpatient facility, for an emergency medical situation is to call 911. So we don't have code cards within our facilities. So that was the case here as well. So CPR was begun, and one of our staff ran down to the outpatient surgery to get an intubation kit. I think that's when Deaconess ED was notified by them, and so an anesthesiologist ran up to our facility to assist.
Okay. Whenever you have a death in a facility, you know you have to contact WSHA, and have to do it within 8 hours, which we did. They came in shortly after and did a complete investigation. WSHA did a full investigation. No violations were cited and no penalties were assessed. But that's something that you should remember. If you do have a death in the facility, you are required in the state of Washington to contact WSHA.
We did a root cause analysis after this investigation. I'm sure all of you in the medical field are familiar with those, and we learned 4 important things. First one, obviously, is one of the factors was domestic violence. Our employee failed to warn or notify anyone in our facility that there was a potential for violence.
You know, we had a lot of unlocked doors for conveniences, and that's not the case anymore. All of our clinics, except for the lobby door, the other doors are secured.
The staff was familiar with this gentleman because they had socialized with him. He had come in. We have a protocol now that non-clinical people do not belong in clinical areas.
And we're still working on our communications. We felt that was a very weak point during this whole ordeal. And even though we have a system called PageGate, we're looking at other options, probably partnering with Deaconess a little better.
Pretty tough to get out notification to 53 geographical locations within a 75-mile span. And we didn't do it very well that day, but we're working on it.
Thank you.
So my name's Adam Richards. I'm the director of the emergency department at Deaconess. So I was just going to go through kind of our perspective and how we played into this scenario with them. I called it a day disrupted. This is the day that nobody wants to have on your campus, in your area. You're hoping that this doesn't happen in your town. So that's kind of one of the reasons why I think we thought this was a good idea to share. All right. So we, you always hope it doesn't happen to you. As Murphy's Law would probably go, much like Barbara, I was at least not on vacation. Did it not go to use? So I was at a meeting with Brian and the local council. There's a lot of us sitting out at the fire training center, and one of the medics flashed me his phone of a page that just went out about this event. So I essentially got the 911 dispatch from the Valley, and so we'll kind of go through my timeline. This is just a brief overview of Deaconess and our capabilities. There's a lot of people on our campus. Much like Rockwood, we have a lot of employees every day. During the day, we're peaked with a lot of staff in-house. So at any one point in time, you can have 300 to 600 employees in the building very easily. So you guys may or may not know some of this. I just gave this picture, one, because it's a nice picture that somebody took for us. The guy that's building our new ER took this picture, but it just kind of shows the geographic layout of the facility. You can see all the different medical office building, the overpass, the main tower, then you've got the OR suites that sit over Lincoln, you've got the connection with Shriners, and then the Deaconess Health and Education building sits on the very top part. So much like a lot of the hospitals in our area, we're just very interconnected through the buildings. There's a lot of ways to get around. There's a lot of access points. And part of what I was going to say is just knowing all your access points to all your hospitals. How do you get around in and out? Much like just having a back door for convenience for somebody to enter, there's a few entrances and exits to this building, a few ways to get in. So go ahead. So I didn't do any specific times with this, but just I felt it was important to illustrate how long it took for the sequence of events to roll out. So I timed it at starting at like a trauma clock or a code clock. At starting at 0, how many minutes did it take? And one of the things that we found out through this event and trying to figure out what happened when was, depending on who you talked to, what cell phone carrier they had or whose clock they were looking at, much like the 8 o'clock time we've got there and the 1:30 clock we've got there. Every clock is different. So establishing any sort of timeline was very difficult. Again, we started our notification probably had to be seconds after the events happened. We started receiving alerts along the way. Our panic alarm sounded at our security desk. We started getting cell phone calls from various employees. And it was all very quick. In about 2 minutes, a call was recorded, in the 911 center, which could be just the time it takes to make a call and connect it or file it, but they were probably all occurring simultaneously. And units were immediately dispatched. We had an overhead page in the hospital, and this was kind of an interesting situation, not knowing everything that's going on. When I called my staff after the 911 patch had come across, I told my staff to be alert because the patch on 911 was that there was an active shooter. And what was paged overhead at the hospital was it was a code blue, which is a man down, CPR necessary, a full resuscitation. So we were getting kind of conflicting information. We didn't know how to handle it. The hard part about this scenario is the people that were in the office knew exactly what was going on and everybody was safe. The people on the outside didn't exactly know that. So it made it a real difficult situation to page out. But basically I told my staff just to be very careful and respond as appropriate, but they need to go up full well knowing what's going on. And so you can see some of the other timelines. In 5 minutes there was staging was established. You can go ahead, next one. Within 8 minutes, I was looking at the call and starting to make my way back to the Health and Education Center, and I was talking to my staff in the emergency department. And again, some of these are internal to me. I started calling my chain of command, the people who work on emergency preparedness at the hospital, to get them to start evaluating what they needed to do. For our hospital, when I called my co-chair, he started notifying the safety officer. We started blocking entrances and exits, not knowing what was going on. We informally posted people, and that was kind of the natural progression. We didn't give out advice. People just started going to entrances and exits and blocking them. They weren't preventing people from coming in, but they were watching each and every person as they entered and left, just to kind of keep a finger on the pulse of what's going on. Go ahead. And again, just some more timelines of what's going on, who's responding. Within 15 minutes, 17 minutes, people are responding and moving into the area. At the 17-minute mark is when I had arrived at 15 minutes after, and I didn't speed. I had a cop right in front of me on I-90. It's terrible timing. Another one of those things. But so I didn't go anywhere. Unfortunately, he was responding to the same thing I was, but he wasn't using his lights and sirens at all. So we were both going very legal-like back to the hospital. And we began with, at 17 minutes, one of the patients had been extricated from that area and moved through the hospital. So from a hospital perspective, moving this patient through was a big blur for everybody, but we had to, we had firefighters working on the patient, and we had, CPR was in progress, the whole bit. It was a big mess, so we had people running up, crossing the terrain from the Health and Education building back to the ER is about a quarter mile distance-wise. You go through the elevators, across this crosswalk, along Fifth Avenue, and then back down the elevator. So we had a lot of people running in front, blocking entrances to offices, closing doors, making sure there was nobody in the hallway. And then about 20 minutes, our safety officer had probably arrived up with John, but they were on the 7th floor, establishing scene safety, making sure everything was safe. But at that point in time, we had already had staff in the area. I had 2 emergency room physicians that were in the office working on the patients and rendering first aid. And that's, you can go one more, but I think that's about all on Brian too. So within about 35 minutes, it kind of stopped. That was the end of it. It stops from a physical aspect. The last patient was declared, but then that patient remained in the emergency department. I think on my next line that I didn't do, there was another 2 hours before the medical examiner arrived. So as you can imagine, it takes a long time to clear that patient out of your emergency department. You have that person sitting there waiting for examination. You can't really move them at that point. So it tied up a room for us for an extended period of time. But that's the natural course of things. So, and then we immediately followed, kind of allowed people to go home and go on their way. We worked with Barbara and Rockwood on debriefing and counseling right at the moment, but then we followed it immediately the next day. We had a hot wash where we pulled everybody back into a room. I pulled out 100 sticky notes and said, write down what time you got a text, write down what time you got a call. If you have any documentation, what time did all this occur? And we put sticky notes on a timeline up on a wall to establish what happened when. And then we went through that timeline and said, okay, this is 5 minutes off. Where did you get that time from? Move things around so we could establish what happened when and how we could react to that better or differently. It's one of the things that I found about clocks being accurate is a huge part of recreating a timeline, because everybody was different. Go ahead, Brian. That's all I think.
Let's keep going. Let's go to the next one. So from my perspective, like Adam and everybody's mentioned, the coordination and the communication on this specific incident was really challenging. We had a lot of players, we had a lot of unknowns, and one of the reasons why, and this is just kind of falling together for me, but when the call actually came into 911, it was reported as a murder-suicide. There were other calls. You can imagine from the Rockwood perspective, they had some people after they heard the shots that you and I are close that reported to 911 that it was a murder-suicide. But around in the same floor in the same building, they had people reporting shots. So there was a little bit of confusion of, is this really the only shooter? Is there another shooter? We're not really sure. That as soon as the police department arrived, they sent an officer up, and he confirmed that that was never shared with the rest of the responders. So we didn't really have that situational awareness. That was probably the reason why the officer was driving under regular conditions, because the police department knew, the fire department did not know. So when I first arrived, my primary job was to manage the medical resources. I met up with the police lieutenant, captain, lieutenant. There were two of them, and they informed me that the situation had already been stabilized up on the floor. There was not an active shooter, so we went directly to the patients. Because the call did go out as an active shooter, we always like to oversend just in case. I mean, obviously it's a lot easier to cancel resources than it is to send resources. So we sent the RTF team, the task force that's responsible for bringing critical medicine to the patient under cover of police officers. They trained together, they worked together. This was a little bit out of the ordinary for the way that we trained them, because they went in under no cover, because there was no shooter, no threat, but we needed the bodies. When I first made, and you can flip the, well, hang on, I'll explain it. I may explain this one. When I first got up to the patient, we realized that we had 2 cardiac arrests, traumatic cardiac arrests, and no real equipment to deal with that. So we used the RTFs to bring up that equipment and start the resuscitations and aid the physicians from Adam's shop. When this happens, regardless of whether you're on the south side or the north side of the city of Spokane, we send about 46 people to fill out all the positions to be able to manage a simple active shooter. In this case, this was a high-rise, and talking this through in our after action and several of our other training experiences, we probably would have tripled this number if indeed we had an active shooter going through the different floors in this high-rise. Because honestly, that is a very complex, and I know the folks, if you guys have SWAT experience, that is a really dangerous situation to go in on multiple floors and clear those floors and those rooms and the cut-up offices and such. So you can expect a pretty significant response from your fire agency, regardless of where your facility is. But overall, you can see the amount of overhead and the amount of doers that we have to do just to support the incident. I shot some pictures, if you want to go to the next one, of kind of the chaos of what we had to do in the small room that we had to do it. There was a code cart that was brought in. This is one of our MSOs, a medical service officer, that came up right after I did. At this point in the photo, the RTFs, which are 3-person teams led by a paramedic that have all the ballistic gear, they're working their way up the stairwells without any cover. They're not really sure what they're going into, because that information was never relayed from the police to the fire department. So they took them a little bit of time to get up there. So the people, if you guys are familiar with hands-only CPR, we want to rotate people every 2 minutes, right? That's our goal. So I needed about 12 people up there in a very short amount of time. Very small quarters, 2 patients. I don't know if the lights are on a little bit too much, but if you can see the floor is completely red. There were, the one was The injuries on one of the patients were simply incompatible with life. That gives you a pretty good idea of what we were dealing with. You want to flip to the next one? When the RTF arrived, those are the goofy-looking people with all the ballistic vests and everything on. They were charged with continuing CPR, which they're doing, and moving the patient from the 7th floor over to Deaconess ER. We were able to successfully intubate the patient, start multiple lines on the patient, and resuscitate as much as we could in that small space. You can flip it again if you want to, and that's just them moving. Unfortunately, the second patient, as we were getting ready to move the second patient, we decided to call it on the scene due to the amount of blood loss and the number of injuries. I think that's all I have. Flip again just to make sure. Yeah, so RTF, the concept of taking paramedics and putting them in ballistic gear, marrying them up with law enforcement and putting in areas of danger are going to become the norm. We did this pilot first about 2 years ago. I know Spokane Valley, Brian's here from Spokane Valley Fire Department. They have the equipment, they have the training, and they're going to be instituting it in their jurisdiction. So I would offer, or I would suggest that if you want to invite your fire agency and run through some of these drills, it would really help in the real world, because we didn't have a whole lot of time. We'd never been in Deaconess in this type of format. The vertical challenge was huge for us, and the complexity of not having the communication. One thing that we did for the communication is we have a new radio system, an 800 megahertz radio system that goes online for us in January, which will essentially put everybody on the same network. And we've never had that in Spokane for 130 years. So it's a pretty big thing for us to be able to marry the communications piece, but we still don't have that today.
My name is Nick Lude. I'm the Director of Quality and Risk, and I'm with Keith Rogers, our Safety Officer and Plant and Facilities Director. And we're just going to talk about our response. So, like Adam pointed out, we are connected directly with Rockwood through a sky bridge. And so, interestingly enough, July for our hospital, we have monthly safety topics. It was preventing violence in the workplace. So we had a lot of activities that we were working on leading up to this. The week before, we had showed a shots fired video to all of our staff. We had changed our visitor check-in process. The month before, we had established this new threat assessment group where if employees, bring concerns up about, domestic issue, we had a process where we could handle it. But of course, just like Murphy's Law, that morning we actually had most of our leadership team were over at our sister hospital in Portland for something. So the way we heard about it was we saw just a big gathering of different emergency vehicles, and one of our staff members went online, social media, and saw that there was a shooting. That's how we found out about it. And so we started our process of locking down the hospital and activating our command center and notifying all the staff. But it wasn't until I think 11:15 until we actually found out the real details of what happened and that it was a murder-suicide immediately. So our whole staff was under the impression that there was an active shooter, and having that connection with Deaconess through the sky bridge, we had, similar to how Adam's team responded, we had folks at each one of our exits just kind of monitoring it. So that's kind of what happened during the day. I'm going to let Keith talk a little bit about some of the lessons learned.
So I actually was in Portland at the time and received the phone call and was with the rest of the senior leadership. So we immediately got online and started to try and follow what was going on. And obviously a lot of information was very fragmented coming in. So we were like, well, do we just get on the next flight? How do we get back? What is truly going on? And obviously the connection between the two is a vulnerability for us. But we're a children's hospital, so we don't look at the risk the same way you would in a hospital with an ER. We don't have an ER. We're very specialized. And we've got a very small staff. Our security staff during the day is one person. So as Dick had mentioned, only the month before we had established this threat assessment group we refer to as a tag team, which is something we had established at the Portland Hospital previous year. We had gone through our visitor policy and changed it so that when people come to visit staff members, the staff member has to now come down and get them. So in a situation where there is a domestic and we call up and say, hey, your husband's here, they have that opportunity to say, don't let him in. So even if we miss things through the threat assessment group, we do have that potential second opportunity to catch something like that. We had just started watching the shots fired video, and that was, people came up to me afterwards and it was like, ooh, Keith, was that a premonition? Or, it's kind of scary because of the events that we had just put in place and then for this to happen. But we are going through our policies again. We're looking at our MOUs. We're looking at trying to establish some type of radio connection with the security folks over there so that we can communicate better and as things are happening, have a true understanding and be able to work more together versus as separate entities with it. But again, we're looking at those opportunities, and it changes every day. You can prepare for one situation, but the next situation won't be exactly the same. And trying to find something that's flexible, having to send somebody out to lock down each door is not necessarily a good idea. I also oversee the Portland Hospital, so our security system there, we can push a button and every door locks. You pull the fire alarm and every door unlocks. So there's you just have to be flexible with it and work together. So I have.
Let's go to Ed Hoffman. All right. I've never needed a mic. I come from a family of 10 kids, so.
Speak directly, so I'll give you this one.
Okay.
That's a personal mic versus a...
Thanks. Can everybody hear me? Okay. So I got to move a little bit. So chaplain, you hear it, you think, okay, bearer of bad news. It is kind of what we're tasked with. When this came out, I had just left the scene of another DOA, and I'd gotten a call to respond to the DHEC building. And for me, it's just radio calling and saying they need you at 5th and Lincoln. There's a murder-suicide. I knew that at that point. But one common thread that I hear talked about here is you don't know what you don't know, right? I mean, it's kind of all through this. So your mind is imagining, okay, what's going on? Well, when I hear it's in the cancer center and it's the murder-suicide, I'm thinking probably some elderly guy felt bad for his wife, but why would they do it there? You know, so your mind's wandering. And I'm a chaplain, not a police officer, and you were probably following me if I was just kind of cruising along. So you can blame me. You're right. You could. But really, what we know is when I get called, it's bad news. It's involving death. And I'm going to be making some notifications. So ultimately, when I arrive on scene, everything's secure. I get up to the floor, start talking with my officers, and find out there's 2 kids unaccounted for. We don't know where this couple's children are, so we're automatically trying to find out where are these kids, where are parents, how do we locate folks. Next thing we know, there is they said that there's the children are at 5th and Lincoln downstairs. Well, one of their friends, one of this couple's friends, had actually had the children with her, and so as soon as I walk out there, here she's got this van parked, and the 2 children are inside it, and one of our lieutenants has this young lady off to the side, and as soon as I said, my name's Chaplain Hoffman, she started losing it. And so our focus is the kids at this point. I mean, fire, all the EMS folks are doing everything they can do, but now we've got to deal with the children and notify mom and dad. So this gal is absolutely pounding on my chest, screaming at me. I walk her to the ground, and then we find out we've got to get her spouse there. We've got to get mom and dad for the victim there. So the whole scene's chaotic, but our next concern with the children is, okay, who's going to take care of them? This gal's obviously been with them, but the whole thing is spinning. Just because what's her role in this? Not that we know that there's any role that she's playing other than she's got the kids. How did this come about? There's all those questions. Detectives move in, wanting to find out from her. We locate where mom and dad are. So we're kind of passing. We go to mom and dad's house. By the time we get up there, they've left. The mother had called this friend and said, did you hear? I think it's Sheena and Chris. And so they're automatically down there. So now we've got to get back down there, try and make that transition to notifying them. I mean, it's chaos at my end. The hospital had their chaplain. We had another chaplain respond to head them off. But ultimately, there's no blame in this room for how anything unfolded, because we don't know what we don't know. And the biggest thing is the lines of communication. I think Brian and I touched on it just when we were sitting in back. The communication's huge. And so to have this going on, to know how do we make it better? How do we as a coalition make people aware of what's going on? One of the things I would say, just in walking into this building, I'm looking at where my exits are. So for you that are in the field, know where your exits are and know who your primary contacts are. I know John, as soon as I got there, John was there. But sadly, the domestic violence is what precipitated the whole thing. And that's where it all stemmed from. I won't speak to our officers' response, our administration's response, other than to say we've organized our DV unit out of this. I don't know how you proactively police domestic violence. It's a pretty tough nut to crack. I mean, you can't just go door to door and knock and say, hey, Ed, you going to beat your wife tonight? If you are, you might want to call us ahead of time. I don't know how it's going to work, but I know we're moving forward. We're trying to take the steps to, at least address it. And I know after the fact, we met with Rockwood, with Deaconess. We did debriefings. They're huge. For those of you that aren't aware of critical incident stress management classes, I would say that, has anybody taken one? Critical incident stress? No, can you raise your hands? So every one of you, if you have any role John could speak to it, Brian could speak to it, but having critical incident stress management people on your team is vital for big and little things, because your tragedy may be just a little different or a lot different than this. But the reality is our peer assistance team came in, we did 5 debriefings for Deaconess and Rockwood. And it was, I mean, when you have their psychology team saying, could you come do another one of these for these people over here? I'm not saying look at us, look how great we are. I'm saying the training's that good and it's that vital to help the people that you work with. You? Is it you? Are you up?
That's exactly right. Thank you.
Look at that.
I think it's Matt.
Yeah,
actually.
I'll let Matt take the lead.
Yeah, Colin's more of an ornament today. Anyhow, I'm Matt Schiller, and this is Colin Donahoe at the Center for Personal Protection and Safety. And I guess I first off kind of wanted to try to connect the dots as far as why we're here. I was invited in by Erica. We had a conversation a couple months back. And unlike these folks that were caught up inside of the actual events at Deaconess, what we do is we're a company, training and consulting company that's based out of Spokane. But in the healthcare world, we've worked with, in one shape or another, about 1,800 or so hospitals across the country, specifically in the areas of workplace violence prevention and active shooter response. And different from the expertise of most of the folks that are up here, what we focus on primarily is the individual. The folks that are on that floor, okay, how are we equipping and preparing them to be stakeholders in their own personal safety? And so the video, for instance, that Nick and Keith, I believe, had mentioned, the shots fired, that was one that we put out several years ago, more for the corporate world. And in 2011, folks from the healthcare community said, hey, this is a totally different animal. We've got public coming and going. There's different high-stress type of scenarios here. And so we moved into creating a customized program for healthcare. So that's kind of the what that we do. But what I was hoping to just be able to share and maybe bring to the conversation is, you know, what I'm hearing, what our folks at the office are hearing from folks out in the field. And this type of stuff, you know, unfortunately is happening, big cities, small towns, everywhere in between, and it doesn't appear to be going away. And so what we've got is a really kind of a need for, okay, what can we do, obviously, to respond to and mitigate damage on the back end of these events, but what can we maybe do on the front end to help recognize and prevent these things from happening in the first place, or at least equip people to be able to manage that as the situation's happening. And so you know, the specific event here, you know, one of the areas that we look at is workplace violence, and it's not uncommon at all for these type of more what we would call an extreme violent incident to spin out of some sort of intimate partner violence, domestic violence, things like that. And you know, there's a couple reasons for that and why we focus on it. One of them being that if this is a relationship that's been terminated, you know, maybe those two have split ways, they're separated. He or she, in most cases he, may not know where she lives anymore. Maybe she's with a friend or family member, but he almost certainly knows where she works, and like we just heard, maybe even has some knowledge of if that person wanted to do some harm, even has a little bit of a leg up as far as knowing how to do that. And so we, again, really work with equipping the individual to understand that this isn't just because my job title doesn't say safety, security, emergency response, emergency management, doesn't mean that I don't have a role in this for the organization, for protecting myself, but also for the company as a whole, or the hospital or facility or clinic or whatever it is. And so moving into the active shooter response, you know, what we kind of lessons learned, and this is perfect example as far as what happened here, but also what we're hearing out in the field on the back end of these events, is these things are over typically in a matter of minutes. Okay, so you've got the onset of violence, and then that gap, which we call the extreme danger gap. We just kind of made that up. But that time between when the violence starts or shooting starts and when first responders arrive, and it's, you know, best case scenario, we're talking a matter of minutes, and somebody in a room with a weapon can do a lot of damage in just a handful of minutes even. And so what we do is we're working with and trying to help hospitals and organizations, and just for conversation, or hopefully we'll be able to add some value to the questions after the fact, is, okay, what can we tell this person that's on the floor, sort of our boots on the ground, someone in admin or in nursing or food services, somebody that's out amongst these people as these events are going on. Okay, what can we teach them as far as recognizing, if something doesn't seem right, it might not be, it might be nothing, but if it's a domestic violence situation, does that person have the mental permission slip as the victim or the potential victim to know that they can go to their leadership, to their manager, to human resources and say, hey, this is going on, and know that they're not having to fear what might happen because of that. And on the other side of it, do those person's coworkers, have they heard stories? People talk when they're at work. That's what we do. Were there any red flags? Were there warning signs? And do those people that are hearing those things, again, do they see themselves as part of the solution? Have we given them the permission to, if they see something or hear something that doesn't sound right, it may be nothing, but nonetheless, who do they go to, and how is that communicated? And does that organization have that threat assessment and threat management team in place to assess those situations as they're happening and take appropriate action? And so there's a lot of what we do on the preparedness side, and on the response is really just trying to get across to people that while we might be limited in resources physically and things like that, and aren't going to have the same response, obviously, as your fire, EMS, and police crews and that. But if I'm in that situation, what can I think about on the front end? Do I know where I typically work, what doors lock, which ones don't, where I'm going to potentially paint myself into a corner? What can I do what objects are around me as far as barricades can I use? If I'm in a room with a patient, the beds are heavy. Can I roll that against the door, lock the brakes, and get behind some other type of door? These little things that we're not trying to make the individual take the place of anything that needs to happen through those other organizations. What we want to do is equip them with enough confidence and enough knowledge to be able to protect themselves until the situation is cleared. And so that's really, kind of in a probably 10-minute nutshell. I don't know how long I've been rambling here, but that's what we do. And so I'm really hoping that, as if there's questions that come in, like I say, more than anything, we just want to be a resource and be able to field some questions, maybe provide a little bit different perspective as far as what we're hearing from folks across the country that are planning for, practicing, and in some cases even responding to and following up on these type of incidents. So, Colin, anything you'd add?
Yeah, I would just say that training all of your people is a force multiplier, and that when everyone is on the same sheet of music as it relates to the prevention piece, but what am I going to do as not only as a survivor but a survivor protector, taking into consideration our patients, and like you said, every situation is dynamic, it's different. No two incidents are the same, and so if you and it may not even be a gun. So if you only train on, hey, if you hear gunshots, but what if it's something else? So it's getting people to think through the what if questions. What are my options? Can I get out? If I can get out, get out. If I can't, hide out, keep out. So just knowing those options, and I love the 3 circles. Your presentation, 3 circles. We actually use a similar diagram that most organizations have 2 circles. It's what we're doing organizationally from a security, maybe an HR standpoint, and law enforcement. Are we coordinating with them? But oftentimes it's that 3rd circle that isn't integrated, which is empowering your people. And like I said, it's a force multiplier to have that teamwork, and it's about being mindful, not fearful. It's not about scaring people. It's you have a better chance of being struck by lightning, truly, than finding yourself in the middle of an active shooter situation. But just like an airline flight attendant gets up and shows you where the exits are, where the lights are, what to do when the mask comes down, they're not making you afraid of flying. They just want you taken through those contingencies. So that's basically in a nutshell.
So speakers, I'm going to ask you guys for the Q&A session if they're to turn your, maybe turn that little mic off. Yeah, that one, Matt. Turn that one off, but then turn your broadcast mic on. So let's take some questions from the audience for our panel. Really? They're wrapping up their mouths.
Yeah, did you say anything about rapid responder, or was it utilized on this event?
So from the hospital perspective, yeah, Dave asked if rapid responder was utilized in this event. And from the hospital perspective, we did not utilize rapid responder. And I'm assuming, again, based on what you know or don't know, that this event was over and some of the people who usually utilize rapid responder already knew what they were going up against. So it didn't become what it could have been as a long drawn out sort of seek and destroy, or whatever you want to call it, event.
Seek and destroy.
I don't know what else you...
Those are technical terms.
I like it.
What's that?
So Rapid Responder is a internet accessible program that gives detailed tactical plans, reports, and contact information for public buildings within the state of Washington, primarily schools, but other buildings have been pre-planned to that extent. All the fire companies that were there, and I think there were 10 or 11 companies, all of them had tactical plans. The same time that they were dispatched, they had that building, the layouts, how to shut down the electricity and all the utilities in front of them. So there was a situational awareness from an architectural standpoint that was shared throughout the fire service, but the police department doesn't have that. If it would have been a longer event, one that we could have established a formal command post and had a little bit of time to plan, we would have brought out rapid responder and had a unified command with the Deaconess. Well, there would have been a much larger organization built if it wouldn't have de-escalated as quick as it did.
You said that you had a critical stress management team. Is that what you called it?
Yeah, we actually have what's our personnel assistance team for any officer-involved shooting, any critical incident. We debrief everything. You know, anything that we deem as a critical incident, we will debrief that. And it's the ICISF, it's the International Conference of Stress Foundation. They actually are the ones that put together the CISM, which is Critical Incident Stress Management training manuals. And I know.
Yeah, we've got a team as well, but we share a psychologist. I mean, not him personally. Yeah. Well, we do that too.
We probably should.
Yeah, we probably should. But we have a psychologist on staff that's split between police and fire that helps coordinate that. But I think the chaplains really have a leadership role in it. She's more of a clinical person, I think, right?
Yeah, she's. So our doc is specific to law enforcement or whoever they're contracted with, whoever she's contracted with fire. But really what makes our critical incident stress management team, our PAT team, so successful, and really from your docs who were on scene for our debriefings, is our team. I mean, because they've been through the critical incidents, and that's who we use, is we use those people that have been through critical incident situations, and that's what our team's made up of. It's people that have been, all of our officers on our team have been involved in an officer-involved shooting. And you don't bring them on right away. You know, you have these people that you build this team around, but it's been a long time building, but the way to get it done is utilize your resources. We're available to, I would say, I don't want to throw this too far out there, have the chief after me, but we get calls from Coeur d'Alene, we get calls from Sandpoint. For all officer-involved shootings, we're available for that, but we're also available to communities any agency in the community that has a critical incident, you call and we'll put somebody together to come help. But that training, it's like you were saying about the whole training is everything. I mean, Brian, your guys do everything. Our SWAT operators, our patrol officers, everything is geared around training. I mean, it becomes that muscle memory, and that's kind of the way our critical incident team has become. We've got enough people that have been involved with this long enough that I don't want to brag, but we do a really good job.
I'll brag for you because you were amazing. Really, your team came in, and that day they began to debrief our employees and patients in a group. The next day, bright and early, 7, I think. The next
5:30, I think, was the first.
Really early. We were all there, and this team debriefed, and I think, well, I know it made the difference in our employees being able to come back to work the next day, within a few days, to that same location. Patients able to come back. A couple of them went out to the Valley location maybe for the first week, but now they've all come back to that location, and it begins with your support.
Thanks for that.
It's amazing.
And it needs to be done fast. I mean, when I first walked in there, the stress was palpable. I mean, you could feel it. Because if you can imagine that small office, I don't know if anybody's actually been in there, but I had a firefighter who was part of the crew that responded there that had cancer treatment in that facility. So I've been there before, and I walked in, and there were people, family members that were waiting for patients that were receiving chemo. There were people on chemo. There were staff, and everybody was just shell-shocked. They had no idea they really didn't have a good understanding of what happened. And the ones that did go close to that, the area where the two were shot, there was blood everywhere, and that's just not something, I mean, that's like a normal day for me, but that's not a normal day for the majority of those people. They don't know how it's going, or we don't know how it's going to impact them. We have a very high number of suicides in our jobs, the police and firefighters. It's just a fact of life, and it's something that we're trying to get our arms around. But one of the best practices is having this program for our people. I think it's self-serving partially because we do want to take care of our people to the most extent that we can, but on the other hand, we want to share that so that you can do the same for your employees, because it's not a matter of if, it's really a matter of when. It may not be as big as this or maybe bigger than this, but something's going to come up, and you're going to have the ability to respond. And I think the chief would be extremely proud that the police department would offer those services. But it always depends what's going on. So, I think you really need to look inside your organization and have that capability. We for years had relied on EAP. Everybody call EAP, call EAP. Well, the reality of it is you call EAP 3 weeks, 2 weeks, a couple days later, then you get to meet with somebody. That doesn't work. You need to get on it as soon as it happens while that trauma is real, and so that nothing untoward happens between the time that they drive home and they leave that facility. Because we do eat guns, and that's in our jobs. It's a normal response to a lot of the stress over time.
And I would just add to that, especially fire, the way that all your calls, I mean, when you're called, when we're called, it's not for, hey, we're having this, this cakewalk over here, and we'd like to know if you'd like to participate. I tell people that our officers, our firefighters, most people will experience 1 or 2 tragedies, 3 tragedies,
loss of a parent, loss of a grandparent in their life. You'll have a couple tragedies in your life. Our officers and our fire EMS personnel, AMR included, they deal every day with everybody else's tragedies, and it's a big deal. And so we know for us that it's essential, and no matter where you come from, no matter how big or how small your agency, it's training that's worth its weight in gold if it saves one person. So consider it.
So Matt, I have a question. As we were preparing for this meeting, I logged onto your website, and you have a lot of resources and information there from the Center for Personal Protection, and you're an option for our facilities if they want to learn more, and you provide services. And I believe you provide services at Sacred Heart, Providence. Actually, some of your video clips I think were filmed there because the videos look really familiar. But I guess one of the things that struck me when I watched one of those videos was just a pretty basic statement that said, and I'm using my own language here, it wasn't what your speaker said, was that you're a lot better off, you're a lot more prepared to respond if you ask the what if question before the incident instead of responding to the incident when it happens, because the stress and the overload that takes place is going to inhibit your ability to respond. And I thought that was a really critical point. So I kind of share that story because there's a lot of other resources on your website, and I just wonder if, do you have a website address that if folks wanted to just look at that they could punch into their computers for additional resources?
Yeah, sure thing. And our website is just pretty straightforward, cpps.com, Center for Personal Protection and Safety. And I've got some cards with me if y'all would like, or I know that Erica and Travis have my info as well. So if anything, even just as questions or, hey, here's what we're dealing with, we're thinking about this, we really, especially being a Spokane company, we want to be a resource. I mean, obviously we are a business, but this is what we do. This is what we live in, and so even if it is just a question or how can we plan forward, how can we better use what we have in place, always happy to help. So for the folks that are online, the address again is cpps.com, Center for Personal Protection and Safety. And for any, Erica, okay for me to have them contact you for my info? Okay. That too.
One thing that I would just add, add to that thinking through that what a lot of the training that we do, it's called stress inoculation training. For those of you who aren't familiar with stress inoculation, it's like when you get a flu shot, right? You're getting a little bit of the flu, so your body recognizes it and knows how to fight it. Same thing is true of stress, that when you put a person through a little bit of the real thing, not the real thing, that memory of what do I do if this tragedy occurs, that information gets logged into the long-term part of your brain. And so when you find yourself in that situation for real, that knowledge will come back to you much more readily. And so I've got four of my kids at Northwest Christian schools out in Colbert, and they're talking about doing a drill with, coming in with live simunition. My mom's a first grade teacher there, and I'm just, you can do more harm than good when you train people if you push them too far. If you you can teach learned helplessness, where people will actually walk out of a training feeling like, if that ever happens to me, I'm dead. I'll never navigate that. And so it's critical that when you're training your people, that it's done in a way that's, hey, we're just giving you the tools to add to your toolbox, be mindful, not fearful, and it goes a long way.
I see other hands shooting up, and in the interest of keeping the agenda rolling, I want to give our panelists a round of applause. So next we're going to make a transition into a subject that's been on all of our minds, right here straight, for the past several weeks since we had our first Ebola patient down in Texas arrive, Mr. Duncan. So we're going to start off with, and I'm going to introduce Susan Joberg, and she's going to do an introduction on Ebola and our regional response, and we'll transition to Dr. Jones. I'm all for a break. Should we take a quick little stretching break?
Yeah.
Stand up, shake it out.